Welcome to the fourth session of Delaware Mini Medical School, early fall 2024, that we're doing in partnership with Bay Health. Always helps if I have my mouse in the right place. Here are our social media links. I think you all know about the program now. I will focus on housekeeping. This is a Zoom webinar. You don't see each other. Use the Q&A feature to communicate with us, both questions for the presenters and questions more logistic about classes and whatnot. Remember, don't ask questions of a personal nature or about family members. We'll do our level best to address all questions. Some we'll answer directly during the presentation. The majority will savor the presenters for the end. You do need to stay through the entire presentation. However, once the presentation is done, we get to the Q&A. That's when you can leave. Although, as I always say, Q&A is when a lot of the good stuff comes out. Today, we are hearing from Paige Generelli and Eric Lair, and I will turn it over to my colleague from the Sussex County Health Coalition, Christy Handley, to introduce them.
Great, thanks, Tim. And I'm pleased to have two guest speakers today coming to us from the emergency room of Bay Health. So I'm going to first talk about Paige. Paige is an emergency room and clinical observation unit nursing professional, development practitioner for Bay Health. Her education, she has a master's degree in nursing education from Chamberlain University. She has a bachelor's degree in nursing from Mount St. Mary College. She has a bachelor's degree in psychology from Binghamton University. In her career, she's had 5 years as an emergency department RN, staff and travel positions, which we hear a lot about these days, and practices bedside nursing within the Bay Health system. Next slide.
Yep, I'm on it. There you go.
And Eric, he's a senior nurse manager of clinical observation unit, Bay Health Sussex, and the Total Care Emergency Center, which I believe is in Milton, correct, Eric?
That's correct.
Okay. His education, bachelor's in nursing from Delaware Tech and Community College, nursing at Margaret Rollins School of Nursing. And he began as a CNA, or a certified nursing assistant, with Bay Health Inpatient Rehab Unit, Emergency and Trauma Services team as a staff nurse, clinical coordinator, and a nurse manager. He maintains bedside presence through assisting critical care patients, performing ultrasound-guided IV insertion, which is fantastic, by the way, and performs patient rounds. I'm going to turn it over to both Paige and Eric. Thank you for joining us.
Thank you.
Thank you. All right, so we're going to start off by sharing our screen.
No, I guess I didn't share.
There. And then do we share with audio?
Yeah.
All right.
Alrighty. So thank you for the presentation or the introduction, and welcome everybody. So on behalf of Bay Health, today's presentation is going to be Fact or Fiction, the Emergency Department Edition. So we're going to talk to you guys about what is emergency medicine, what the role of an emergency department registered nurse looks like. We're going to have a Fact or Fiction section, and then the Q&A. So there's a disclaimer just to let everybody know that there are going to be various images and videos utilized throughout the presentation, which depict adverse medical events, which are both real and fictional.
And then at Bay Health, we use something called AIDIT, which is an acronym for all of our interactions with patients, guests, and peers. AIDIT actually stands for Acknowledge, Introduce, Duration, Explanation, and Thank You. So we're going to give you a little bit of a AIDIT about ourselves in our presentation tonight. So for Acknowledge, hello, Delaware Mini Medical. Thank you for participating with us tonight, and we look forward to providing you with some great information towards this webinar. My name is Eric Lair, and my title is Senior Nurse Manager at Bay Health Clinical Observation Unit at the Sussex campus, and I'm also responsible for the Total Care Emergency Center down here in Milton, Delaware. I've been with Bay Health for 15 years this year. As they said, started off as an inpatient rehab CNA, and I've worked my way up to my nurse manager position. Prior to this, I actually used to build in-ground swimming pools. So this was a second later in life career for me.
And I'm Paige, as Christy had mentioned in our introductions. I am the nursing professional development practitioner for the emergency department. So that's a really fancy way of saying that I do all the education for the nurses, nursing assistants, techs within the emergency department. So I love education. I'm excited that we're able to come on here and teach you guys and interact with you. I also started out my nursing career as a nursing assistant. Became a nurse, and then now am in a leadership position, as is Eric. But what's important to note is that with nursing, there's such flexibility that even as you become a leader or work your way up through administration, we're still lucky enough to be able to work bedside, maintain our skills, interact with patients, and continue to do the exciting stuff at the bedside and not just all the desk stuff.
Agreed. So for duration, this webinar is scheduled to run approximately 45 minutes in total. Explanation, we'll be presenting a PowerPoint for about 30 minutes, followed by a Q&A session. So please prepare all your best questions for the end. And then thank you all for joining us, and we look forward to your feedback at the conclusion. So what is emergency medicine? Emergency medicine is the practice of medicine that includes the evaluation, diagnosis, treatment, coordination of care among multiple clinicians, community resources, and dispositions at the end that require expeditious medical, surgical, or psychiatric care. In truth, we see it all and we do it all. As far as nurses, our role in emergency medicine is to work alongside of the ED physicians and medical professionals to diagnose and treat patients. We come from all sorts of backgrounds. You see Paige has a psychology background on top of her nursing credentials. And all of that is a coordinated effort of foundational education and college work to prepare ourselves for the bedside role. So a little bit of a differentiation between the roles of, say, an ED physician or mid-level versus what an ED nurse may do is ED nurses are responsible for triage, nursing assessment, carrying out orders, direct patient care, and then discharge and mission of transfer of patients. Whereas the ED physician and mid-levels are responsible for assessment, ordering of higher level interventions, higher level treatments, medical diagnosis, consults, and dispositions.
So now that we've kind of gone into our role and information about becoming a nurse, we wanted to break down some examples that we see frequently in the emergency department. We have divided them up by body system related emergencies. So we're going to go through cardiac emergencies, which is the heart, your neurological, which is your brain, trauma, which is any kind of trauma injury, and then respiratory, which is your lungs. So the first one we're going to go through for cardiac emergencies is a myocardial infarction. So what is a myocardial infarction? It's a fancy name for a heart attack. There are two major types of heart attacks that we see. So we have non-STEMIs and STEMIs, with the more emergent of the two being a STEMI. So what does STEMI mean? It stands for ST, elevation myocardial infarction. So for us to know what type of heart attack the patient's having when they come in with chest pain or suspicion of having a heart attack, we do an EKG. The EKG measures the electrical rhythm of the heart, and it prints out onto a rhythm strip, as you can see in this picture. So the top one is a normal sinus rhythm, which is a normal rhythm for a patient. The one on the bottom is that same rhythm, but with a really elevated ST segment, which is that area there that's ballooned up. So that is really concerning for us. If we see that, the ED physician sees that, we're concerned this patient is having an active heart attack. So in addition to that elevated ST segment, which does indicate that there is cardiac tissue death happening, we also do blood work, which will indicate the release of a cardiac biomarker called a troponin level. So if the troponin is elevated, we're also worried. We're thinking that heart is working way harder than it's supposed to be. So what does it look like? When someone comes in, there can be a variety of complaints. So it looks different for every single patient. A lot of times age, gender, and race do play a factor in how it presents when you're having symptoms. But in general, they'll have chest pain or pressure, which radiates sometimes to the back, to the jaw, arms, or shoulders. They'll complain of palpitations or arrhythmias, meaning they're feeling their heart racing, they feel a skip a beat in their heart. Dyspnea, meaning they're feeling short of breath. Diaphoresis, so they're sweating, even though they don't have a fever, they're not hot or cold, they're just sweating. Nausea, vomiting, fatigue, weakness. Pallor and cyanosis, meaning that their skin color is off, maybe they're pale, maybe they're a little blue tinged. And then anxiety, restlessness, and apprehension are common signs and symptoms. So what's actually happening to the heart? So our heart, like any other muscle or body part or organ, requires blood flow and oxygenated blood in order to function. So your heart, although supplies blood to the whole body, also needs blood to function. So the heart supplies itself its blood flow through coronary arteries. When these coronary arteries have partial or total occlusion due to plaque buildup and a blood clot formed that is now blocking that perfusion, now the heart is not going to be able to function properly, right? Because the blood flow is not going to the heart to pump. So what do we have to do? We have to quickly get this patient medicated and to a cardiac cath lab. Cardiac cath lab is a separate specialty that is under the cardiology department where the patient will go in. They utilize dye to through an artery to determine where the clot is and either place a stent to open up that artery, or sometimes they'll determine the patient needs surgery and then they'll have to have surgery to bypass that artery in order to reestablish blood flow to the heart.
So sometimes when you have a heart attack, what can happen is you can actually lead to a cardiac arrest. So the electrical workings of the heart send impulses down the center of the ventricles and the heart chambers to actually innervate and to help form the muscular contraction of the heart. When that flow is impeded, you can end up with a cardiac arrest. And what a cardiac arrest is, that means the heart stops moving completely. As Paige touched on, the blood flow of the heart is important because that's what circulates all the oxygenated blood throughout the body to the central organs that keep them perfusing. So most heart attacks do not lead to a cardiac arrest, but when a cardiac arrest occurs, heart attack is a common cause. Other conditions that may disrupt a heart's rhythm and lead to a cardiac arrest can include bundle branch blocks and different types of arrhythmias. So the important piece of a cardiac arrest is truly circulating that blood flow again. So from an emergency department standpoint, it requires a true team approach in order to get the body recirculating again. So you can see here in the diagram, there's depictions of the various roles for nurses in the emergency department in the event of a cardiac arrest. So the most important is that of the compressor. So they're doing chest compressions manually to get the blood circulating through the body again. Another important piece of that is the monitor individual, because they're going to attach leads to the chest that can help send electrical impulses to reestablish that electrical flow and circulation of the heart. And then another important roles are medications. We give epinephrine frequently to try to help encourage the heart muscle to get working again, as well as team leader, because team leader is kind of responsible for the communication and flow of the whole team. They're crucial in ensuring that we have good communication and everybody in the appropriate place for during a cardiac arrest.
Okay, so moving on from cardiac, of course, there's many, many more other emergencies and diagnoses that we see. We're just touching upon the big ones. So moving from cardiac to neurological, big one is stroke. So what is a stroke? So you may have heard of it as a cerebrovascular accident, a CVA, or a brain attack. So similar to a heart attack where there's blood flow that is blocked and is causing tissue death, a brain attack or a stroke is a blood flow cut off to your brain. So when you have cut off to the blood supply in the brain, we have to do early recognition and early treatment in order to reestablish blood flow so that we can save brain tissue. So the longer the patient goes where that area of the brain does not get blood flow, the more cells die in the brain. So if someone on the street, someone is having a stroke, there's an acronym called FAST, which everybody should know. If you see face drooping, Arm weakness, if they're having speech difficulty, it's time to call 911. So there are two major branches of stroke. So the first one is the ischemic stroke, which is a blood clot blocking the blood flow. The other one is a hemorrhagic stroke. This is rupture and bleeding of an artery or a vessel. So for ischemic stroke, there's a blood clot. So again, similar to the heart, there's a blood clot blocking the blood flow in the artery. So if that's the case, we can do interventions in order to re-establish blood flow. A hemorrhagic stroke can occur in different areas of the brain. So if it's occurring within the brain, it's an intracerebral hemorrhage. If it's happening in the subarachnoid space, it's a subarachnoid hemorrhage. And there are a couple other different hemorrhages you may see. But essentially, the big difference is ischemic stroke is a blockage within, and a hemorrhagic is a brain bleed. It's coming outside of the artery and bleeding into the brain tissue. So for ischemic stroke, this is something that we can hopefully reverse or improve the symptoms of the faster that we get the treatment to the patient. So we have blood supply that is being blocked by a blood clot. If their patient is brought to a stroke-capable facility within 4.5 hours of their initial symptom onset, we can give that patient a thrombolytic, and that is a nurse function. So the neurologist will say, okay, this patient is a candidate, they're within the time frame, they have no contraindications, let's give TPA or TNK, which are different thrombolytic medications that we can give to bust up that clot and reestablish perfusion. So the patient has to have a CAT scan first to determine that this is the type of stroke that they're having. If they're having a hemorrhagic stroke, we don't want to give them a thrombolytic because that will cause the bleeding to be worsened. So this patient here in this picture had a blocked middle cerebral artery, which caused this blank area of the brain where you can see that there's no blood flow. They put dye through it and they're seeing the dye stops. There's no perfusion to that area of the brain. This patient was a candidate for TPA. They got the medication through the IV. After the medication was instilled, it busted up the clot, and now there's perfusion there again. So you can see all those branches there that were not getting blood flow. All of that area to the brain was dying without blood flow until we gave them this medication, and now their brain is back to functioning. So for hemorrhagic, this is an image of that. So this is a pretty clear picture. They're not always this large, not always this obvious, but on the left side where A is, you have a regular brain, no bleeding, you have a midline down the middle. And then on the right-hand side, you can see that big area of white opacity, that is a bleed within the brain. So another problem that occurs, aside from the fact that someone's having bleeding inside of their brain and all of that tissue is being affected, you also have a volume that's growing inside of the brain, causing a shift of your midline, which can then cause further brain damage and brain death.
So some of the more common injuries that you may associate with what we do in the emergency department is traumatic injuries. So what's a motor vehicle collision? It's an unintended event which causes injury and damage to motor vehicle and transport. This is often determined by severity based on mechanism of injury, the manner in which the human body is affected during the trauma, and then the forces of the collision. So all the factors that go into this are speed of the vehicle, whether there was an entrapment, which is where the individual is stuck into the compartment of the vehicle. A big concern in this particular instance for us is the fact that this vehicle rolled over. There could potentially be an ejection, which would be where the patient exits the vehicle and ends up being thrown from the vehicle. When we take a look at traumatic injuries, we try to take a standardized approach to make sure that we don't miss things when we're looking at a trauma patient. So regardless of what the trauma, whether it be an MVC or a gunshot or a stabbing, a burn, we use the same acronym to make sure that all our bases are covered. So we utilize the assessment that you see here on the screen. A through E are primary assessments. So we're looking for alertness. We're making sure that the person sitting up can speak to us. We make sure that their airway's intact, that there's no stridor and difficulty breathing. We also look at breathing to make sure that there's no asynchrony between the left and right chest wall, that there's not any breath sounds. For C, we make sure that there's no external bleeding or any kind of hemorrhage that we would need to intervene with quickly to stop the patient from losing a heavy blood volume. And then we also look at their neurological status. So we make sure that they're able to open their eyes, able to speak to us, and interact appropriately. And then E, we make sure that regardless of the event, that we remove all their clothes so we can look at the full scope and make sure that there's not any injuries that we're missing.
Yeah. So what we talked about when we were discussing this slide is that sometimes the collision might not look that bad, right? So from the picture, it looks like the front just crumpled in, but the patient was wearing their seatbelt and they're okay. They come in, we do this primary survey, and it turns out that there's a lot more damage that was done, even if it didn't look like the mechanism was that bad. So it's just really important that we take every traumatic instance seriously, and we do the same standardized approach so that we don't miss anything on assessment. And we do this in conjunction with the medical physicians.
So as you see in this slide, this is not something that we would be able to miss. This is penetrating the wound. So a penetrating wound is any foreign object that pierces the skin and enters the body, creating a wound. So in this instance, obviously this is a stabbing, but believe it or not, a gunshot is also a penetrating wound. The concern with these types of injuries is not the injury that you can see externally, but it's the concern for the damage to the underlying organs. So in this particular instance, this is a close impact directly over top of the patient's left lung. And anatomically speaking, the heart kind of defers to the left side of the body. So in this individual's case, the dagger ended up actually scraping the side of this heart, but this individual, believe it or not, made out well and did survive his wound.
Okay, so respiratory emergencies. So respiratory distress is when a person is working really hard to breathe and they're not getting enough oxygen. So this can look different depending on the patient, their age. We see everybody, right? The emergency department, especially Bay Health, we are a pediatric capable emergency department. So we as nurses are responsible for taking care of patients from birth to death. Some ERs are adult only and some are pediatric only, so depending on where you work, but for us, we see it all. So if a baby comes in, we're going to show you a video in a second, that's having respiratory distress, obviously we're going to take that seriously, and we want to do early recognition and intervention in order to restore ventilation and oxygenation. We would likely intervene with respiratory therapy with our physician, apply oxygen that's appropriate, give medication to open up the airway, and to reverse whatever cause is of the respiratory distress. Respiratory distress is serious. We take it seriously. Again, it's an emergency. We need to quickly act so that the patient doesn't get worse and progress. So in this video, you're going to see an infant, and you're going to see a couple of things that we would be alerted to as a primary nurse in the ER. First is grunting. So you'll hear a grunting sound. You'll notice that the respiratory rate is very fast. So the baby is experiencing tachypnea. You'll notice that the breaths are not full. They're very shallow. So we would consider that to be like diminished shallow breathing. And then the baby does have retractions. So retractions is when you're breathing in so hard, trying to get a deep breath, that it's pulling the skin from the outside. So you'll see under where his ribs are that he has retractions as well. So we'll play this video for you.
There we go.
So this can be scary for parents, for people, for nurses that have never seen a baby that's in respiratory distress before. But rest assured that this type of thing is what we're here for, we're trained for. So babies come in like this, we take them immediately to the room and we start working. We give oxygen, we give medication, we give support, and we make sure that the baby's okay. On the next slide, we discuss where if a person is in respiratory distress and is not treated quick enough, maybe they had respiratory distress at home, didn't want to come in, didn't get to come in quick enough, and then they went into respiratory arrest. So respiratory arrest is the organs have not gotten enough oxygenation and they're shutting down. So one of those organs is your heart, right? So if you are not breathing, none of your organs are getting oxygen, including your heart, then your heart stops. So similar to a cardiac arrest, but the heart is not the cause of the arrest. It is a secondary effect from your lungs failing, which then fails the rest of your body. So any vital organ, right? You need oxygen, you need your heart, and you need your brain in order to function. Usually respiratory arrest is caused by an airway obstruction, decreased respiratory effort, or respiratory muscle weakness. So if someone goes into respiratory arrest, we reestablish circulation, but we also have to reestablish respiratory, and that will usually reverse the arrest. So what we'll do is we'll put a breathing tube down the patient's throat. This is a physician driven procedure. So they put an endotracheal tube down the trachea, and that gets hooked up to a ventilator, which you can see kind of on the side there in that picture. And that delivers breaths in and out of the patient's lung, and essentially it's breathing for them. So this is something that we do very frequently in the emergency department, as well as intubating patients who are having respiratory compromise.
Of particular note, respiratory arrest was probably the biggest cause of intubations during the onset of COVID originally. So we were seeing a lot of injuries to the lung tissue related to the initial round of COVID when people were very sick. So they were actually intubating individuals and then turning them over on their bellies. So they would be upside down in the beds with these tubes still in place to help try to ventilate and oxygenate these patients.
Mm-hmm.
So now we're going to go to our fact or fiction section of the presentation. So we've gathered some pictures and some videos to show you the difference between reality and what the media may show you as far as medical treatments. So we want you to guess whether or not the media is realistic, or if you can identify what is wrong with it if it's not. So we're going to show you a couple different scenarios, and then if you can use the Q&A section and just formulate your thoughts, we'll check those out.
Sergeant Grant?
Captain, Mr. Personality over here started coughing, grabbed his side and fell over. Could be appendicitis. I'm not sure. All right, back up.
Please. Sir, I'm just going to examine you for a second here. Oh, okay. We got a colostomy bag. Probably back it up. You're going to have to intubate him. Sir, just try to relax. These paramedics here are going to attend to you.
Okay. So, fact or fiction, patient is on the ground, has a colostomy bag that's backing up, so we have to intubate them, which means put the breathing tube down, right? So take a second and think. Okay, so this is fiction. So there's a couple different components to this. So first and foremost, the colostomy bag looked pretty accurate, right? So that was there, but a paramedic would not immediately jump to intubating a patient, especially in the field, because the patient had a colostomy bag that was backing up. So a colostomy is a surgical opening of the colon to the abdominal wall, which is created for the discharge of stool. So your colostomy hooks into your intestines, which then your GI tract goes up to your stomach, et cetera, et cetera. So if a colostomy bag is full, the stool is unable to come out, you may end up having an obstruction or a blockage. And then anything that is ingested then has nowhere to go, right? Because we're blocked. When that happens, the patient could vomit. Anytime a patient vomits, whether it's from obstruction, a blockage, or just vomiting in general, there's a risk for aspiration. So what that means is that the patient could breathe in their emesis or their vomit into their lungs, which is a concern for the airway. However, we don't put a breathing tube down someone's throat just because there's a risk that they may aspirate on their vomit. So there's many other steps we can do first before we get to that extreme. So in the ER, if someone was in there and they were vomiting a lot and we were concerned that they were going to breathe in their emesis, we would reposition them to protect the airway. So we would sit them up or we would lay them on their side. And then we would likely work with the physician and the other specialists and decompress their stomach with a nasogastric tube. So a nasogastric tube goes in through the nair. So in this picture on the right-hand side here. Then it goes through the nair, down the esophagus into the stomach. We can hook it up to suction to pull out emesis and vomit. So if a patient came in and they had an obstruction or a blockage somewhere in their intestines and they were so full of food and things that could not pass and digest that it had to come back out, we would put an NG tube in and suction it out. That would protect the patient's airway because now they're no longer physically vomiting. It's being controlled and taken out for them. So you can see here on the left, this is a picture of the colostomy. And so it's just essentially rerouting the stool into a bag. So the GI tract is different from the respiratory tract, right? So the trachea is in this picture on the right as well. That is where you have your airway to your lungs. They are not one and the same. And one backed up colostomy does not immediately go into your airway. Not realistic. Really just makes me laugh. And when we were making this presentation, was the first thing I thought of was that scene because it's just so silly.
It's Paige's favorite clip, that's for sure. All right, we want you to take a look at another one. This is just a picture. And just take a second and just look at this, and we want you to think about whether this is fact or fiction. All right, so this too is fiction. And part of this has to deal with actually a couple different things. So the patient's being shocked using a defibrillator, but the placement is wrong. So you can see the paddles here are up around the patient's collarbones rather than on the anterior chest wall where they should normally be. In mainstream media, this is also a false depiction because they utilize these paddles instead of a pad that we normally would for the dramatic effect. So basically what we do is shock the patient with the pads, and you'll see in the next picture here of what the reality is. So typically in the emergency department, we use the more greener looking, so 2B and 2A. This is an anterior posterior pad placement, and if you see where they're at, it's directly over the heart. So what that does is it forces the electrical current through the heart to try to stimulate things. Another option would be the anterior lateral placement here, which is also acceptable because the electrical current would then run laterally, so to the side, in order to try to stimulate that heart muscle.
Right, so the patient is, when they're shocked, this is another thing too that we didn't have a video of, but a lot of times you'll see on TV, they'll be in asystole, which means they have zero electrical activity on their heart. If your heart has no electrical impulses, shocking it is not going to create an electrical impulse. Your heart must have at least an unorganized, some sort of electricity still functioning. When it is functioning, it might be quivering, it might not be actually working appropriately. It will be an unorganized rhythm, and we can shock that. And the idea is to shock that heart into an appropriate rhythm. But if you see them flatline, beeping's going on, there's nothing happening, and they go to shock them, you're going to be like, no, we don't do that. We don't shock asystole, we don't shock flatline. We shock irregular rhythms that are chaotic, pulseless, and can be shocked back into an organized rhythm. And to Eric's point, we use the pads, not the fun paddles anymore. I think they used to use those.
I've only seen them on TV. I've never seen it in actual function.
So we use pads now. A lot less fun.
All right, so we got another video for you guys. Take a look and tell us what you.
Okay. So think about that for a second. So that is a big no-no. Legally, ethically, not good. So this patient had a DNR order, which is a do not resuscitate. Recently, it's been updated, the verbiage, to do not attempt resuscitation. It means the same thing. It means the patient completed this document with their physician. It's a legal binding document while they had capacity to do so, and said, in case of cardiopulmonary arrest, I do not want X, Y, and Z to be done. So depending on the patient, they may say, I don't want to be intubated, but I'll allow compressions, or I'll allow everything, or I don't want anything. So if they say do not attempt resuscitation, or they have a DNR, they don't want compressions to be done. And that patient in that video had a DNR, as the other physician had mentioned. There was that DNR sign in the back of the room. The physician ignored her DNR and provided resuscitation to a patient who explicitly did not want this to be done, which is a violation of her advanced healthcare directives. So in a real life scenario, this physician would be liable and could face a medical malpractice suit because they explicitly violated the patient's wishes. So if an individual fills out a advanced directive, it basically lets everybody know in the future if something were to happen, what they want done. So this is an example here on the right for Delaware of what a Delaware medical orders for scope of treatment looks like. And we do take that seriously in the ER as well. So if we have a patient that comes in that might be end of life care, they've filled out documents saying they don't want to be resuscitated, then that is typically has to be followed because that's what they requested while they were able to make their wishes known.
All right, one last one. So this is just a picture, and I want you to just take a look at it for a few seconds and tell us if you think this is appropriate or if you think something's off about this. So this is another example of fiction. The device that's actually in this young lady's mouth here on the left is what's called a Yankauer. So this is used for suction, as Paige was talking about earlier with the risk of aspiration. Say somebody vomits and they're laying on their back, we utilize this device to remove the secretions from their mouth. This actually will do no good in providing any type of oxygen or any types of life-sustaining means to the patient. So as you can see here on the right picture, this is the endotracheal tube, and it's connected to the ventilator circuit back here. This is what an appropriate ventilator set looks like. You can see that this is secured to this individual's face. That way the tube cannot become dislodged and potentially interrupt their respiratory process here.
That was really it. So, I mean, honestly, fact or fiction, basically just fiction, all of it.
Everything is fiction.
Most things I find when I'm watching TV as an ER nurse and are happening, I am usually like, that is not accurate. That is not true. Do not trust that. But occasionally they'll do things right, you know.
I think they're getting better as the time goes on to actually appropriately portray things.
Yeah.
One of the nice things about the clip in which the patient intervened on the DNR aspect is that kind of is true to life in some regards. You saw the team there, you saw the compressions happening. So we're going to open it up to you guys and answer any questions you may have. We certainly appreciate your time and your attention, and we're eager to see what you guys come up with.
All righty. First question. How do you balance sadness, care, and concern with job performance?
I think that's a great question. Unfortunately, in our roles, we become kind of attuned to sadness. We see people on typically the worst day of their lives in most instances. The nice piece about us is 98% of those patients we can probably help out and have a positive ending. For that other 2%, there's loss that occurs, but as you go through the years of working in the profession, it's almost nice to help people get to their final place as well. I think there's a balance in the nursing profession of being able to heal the body, and I think there's a balance of being able to heal people as they kind of transition to their final resting place.
We also do have things through the hospital, depending on where you work as a nurse, but as an emergency room nurse, typically they will offer assistance. We'll do moments of silence. We have something called CISM here where they come and talk with you and debrief and discuss what happened if it was a specifically traumatic event that you witnessed. There's a lot of communication and I think a lot of teamwork too. So I think that you become very close with the team that you're working with because you do experience these stressful and sometimes sad events, and you learn to lean on each other and build resiliency throughout your practice.
All righty, hold on. Again, I'm doing too many things at once here. Where did that window go? All righty. So you showed us a number of videos that were fiction. And Nathaniel asked, are there any medical shows or YouTube resources you would recommend for this type of study that are real, that are accurate?
I don't know of any YouTube videos off the top of my head. A lot of the resources that we utilize from a hospital standpoint are reputable resources. So we make sure that we look at .org type information, and we use UpToDate through our system here. And we have our own internal clinical references that we look to. But from the layperson standpoint, I don't know that there's a true site that stands out in my mind. I would almost recommend hitting the library and maybe pulling some of the a book.
A what?
A book, believe it or not, right?
I don't use books.
That can be a good source of true reputable information.
Yeah, I don't know like if I would give any kind of recommendation as a medical professional, but I will say I did watch one show that I personally thought was pretty close, and it's called Code Black. And it really showed the chaos of an emergency room, and a lot of things they did do in that show were pretty close. So all of them, I watch them all. Grey's Anatomy, Chicago Med, 911. Trust me, I'm a medical aficionado with television. I would say that's probably my closest one to being reality was Code Black.
All righty. Anshika, make sure you ask your question in the Q&A. We don't do raised hands. Okay, what does day-to-day work like, and is it tiring?
So our day-to-day is a little bit different than the bedside nurse. I'm going to speak from the perspective of when I was doing bedside care. I used to do 12-hour shifts. So your morning starts at 6:30, and typically you should be getting out around 7:15. I can tell you that there were many days that I didn't leave till 9, 10 at night, because if there's a need, Paige kind of touched on the team focus in the emergency department. We are all very good about making sure that we don't leave our team behind. So they are very long, they're very tiring days. The interesting piece about our units versus say an inpatient unit is our days never stop. So whereas a normal inpatient floor may cap out at 24 patients, we may see 120 patients in an emergency department during the day. So there is always a constant influx that we're just churning over, and it can be tiresome.
And no 2 days are ever the same.
That's
Ever the same, which is really
true.
cool. And that's why a lot of ER nurses like being an ER nurse, because you get to see something different. You get to learn something new every day.
So I'm going to take over for a little bit, and I'm going to ask you a combined question, and it really has to do with the DNR and the DMOST form. So one, if a patient fills out a DNR and they come to the emergency room and there's nobody with them, one, you're not going to really know. And if they're unresponsive, you're really not going to know if they have that DNR. So what do you do? Like
So
at
we
that point,
we always default to resuscitation. So unless we have an explicit document that is accurate and up to date and filled out appropriately, then we save the life first. And then, from there, if the family comes in later on and says, oh no, they have a DNR, then maybe we'll transition from what we're doing, if we did get pulses back, to more of a comfort care and then wean them off. But always, first and foremost, if we don't know, we act and we save, because you can't undo, if you don't do it, you can't undo that. But another thing that I did learn from one of my patients many years ago, but I thought was a great idea. She had a DNR and she had it in an envelope right on her fridge, labeled for EMS. And so she was like, that way, if I ever went down and they walked in, they would see it and grab it. That way they knew what my wishes were when I went in.
And the other thing is we're only half of the piece. So we're the hospital piece. There's a whole pre-hospital piece that occurs before us. So there's typically contact between the paramedics that would go out and retrieve a patient off of a scene. So say they fell out in their kitchen, the paramedic goes into the home and starts initiating that treatment. So generally, from the hospital standpoint, we continue whatever they've started until the family shows up or we're able to have communication with a next of kin or something.
So talk to the group a little bit about and this is if you know the difference between the DMOS form and the DNR paperwork. Is there a difference?
So DNR, typically a DNR is written in an advance directive with a lawyer. The DMOS form is typically filled out in a hospital setting. Generally, if a patient becomes critically ill, the DMOS form is presented to them to have their wishes met in that regard. So you can, obviously can't pull up the form now, but there's specific criteria on there as far as initiating compressions, whether they would be interested in artificial nutrition, so TPN, PEG tube feedings, those type of things. All of that's listed on the DMOS form, which is also a common finding in the legally prepared advance directive.
Thanks, you answered that perfectly. Really quickly, how much time do you have with making a medical decision in the ER?
It really depends, right?
Depends on the instance.
Yeah, but oftentimes we're grooving and moving. We don't have a lot of time. We have a lot of patience. Our physicians obviously are the highest level of medical preparedness in the ER, so we work closely with them to say, hey, I think this patient needs this, and they'll be receptive to that, or they'll say, hey, Paige, I need you to do this in this patient. But we often have to make decisions quickly, not only to save that person's life if they require immediate intervention, but then to move on to the next patient who might need immediate interventions to be done. So it's constantly a prioritization and time management of the entire emergency department, your entire assignment, who's the most critical, who needs medical care immediately, and what we're doing with them, and then moving on to the next one.
Yeah, I think that's a really important point. We utilize triage in our roles, and that's allows us to kind of determine who needs to come back first, what resources we need to put on this patient, but maybe we can wait on this patient. Triage is crucial in our roles because a lot of people, while TV portrays one thing, not all of our day-to-day is actually very sick patients. Probably 5% of our patients are acutely ill that would end up with a cardiac arrest or end up intubated. A lot of what we see on a day-to-day basis is abdominal pains and shortness of breaths and chest pains. So we really try to prioritize that and meet the needs of the patients that are the sickest first.
Great. Nicole asks, how fast does brain cells die during a stroke? Also, if you do not shock a person with electrical signals, what do you do in that situation?
So I don't know exactly how fast they die. I can't really answer that question. They basically teach us in nursing school that time is tissue, and so that every second counts. So as soon as that person started having symptoms, we want to get them reperfused as soon as possible. I think everybody's different. The degree of blockage also determines. So if it's partially occluded and there's some blood flow, then that tissue may live longer. If it's a full occlusion and it's blank, like that picture we saw, that tissue is now dying slowly or more quickly than if it was a partial occlusion. But for your second point of your question, that's a great question. So when we do CPR and when we're resuscitating a person, our first and primary responsibility is to do chest compressions. And this is important for anybody that's trained in BLS, anybody that can do compressions to somebody on the street. The first thing you want to do is to put your hands on that chest and start recirculating that blood for them manually. So by pressing on their chest, you're pushing that blood out of their heart to their body, and that's really what's perfusing their body in order to be able to come back to life. So if they are flatlined and they have no electrical activity, we are manually contracting the heart by doing the compressions, and then we give medications, and those medications can assist with the compressions. And then if we can, reverse the cause of the heart attack or the cardiac arrest. So if the person went to cardiac arrest because they had a really low electrolyte, and now during that resuscitation, we replace that electrolyte, we're doing compressions, we're giving epinephrine, there's a chance that we can get that patient back. So it's a multifaceted thing, but the most important thing for a cardiac arrest is always going to be compressions first.
Compressions first.
Yeah.
So if you're not CPR certified, can you perform CPR?
We all have to be CPR certified within the hospital, but from a regular real world scenario, absolutely. I would recommend watching that YouTube video and seeing where hand placement. That is a phenomenal skill to have to save a life. And I can tell you, you never know when you're going to need it. I was down on the boardwalk in Rehoboth one day, and a patient dropped down, and I didn't even have to intervene because the people around knew how to do CPR, and it was it ended up being a positive outcome because of that quick intervention.
And I know that sometimes if you call 911, then they can assist in, the dispatcher will assist in coaching on how to perform CPR until somebody with medical training can get there. So of course, if there's nobody more qualified than somebody that's not trained in CPR can start compressions until an EMT, a paramedic, a nurse, a doctor, somebody with the credentials can then take over. And they do offer, I'm sure you probably have to be an adult, I'm not sure about that, but they do offer a lot of times in the community BLS classes that you can sign up for to get certified on your own. There's a cost associated with it, but that is something that, you know, bus drivers or people who are teachers and work with people can get certified to have BLS as well.
So this is a question about NG tubes. Can NG tubes come in bigger sizes than 18? If not, why?
I can't say I've ever seen a NG tube bigger than 18. My assumption is that's probably a manufacturer limitation. But with that being said, I don't know that I would want an NG bigger than an 18 French inserted in me. That's a pretty big.
That's a big tube.
Big tube.
And when we put them down patients, especially patients that are conscious and awake, we have to put it down their nose, down the back of their throat, down their esophagus, into their stomach. This area here is very narrow, so it's difficult to get that NG tube down from the nair down the back of the esophagus. And it's very irritating. Patients often experience discomfort. They're coughing, they're choking, they feel like they're gagging because you are pushing past their gag reflex. So we would want to do the smallest amount of harm to the patient, especially if they're awake. So we would use the smallest NG tube that would be feasible to achieve what we need to achieve. So even if it did come bigger, we wouldn't use it any bigger than that.
What are the characteristic symptoms? What symptoms differ from a TIA and an ischemic stroke?
The symptoms likely mirror each other between a TIA and ischemic stroke. The difference would be the length of symptoms. So generally with a TIA, you'll see a resolution of some of the symptoms. So let's say there was numbness, tingling to the right hand. Over time, that may resolve within a few hours, and that would be kind of more indicative of a TIA versus a full ischemic stroke.
Right. So TIA is the transient ischemic attack. That's your body's warning sign. I have decreased blood flow to this area of my brain. It's not fully occluded. Something bad is happening. There is a partial occlusion, and I'm warning you that I'm going to have an actual stroke. So your TIA is often a diagnosis for a patient that, as Eric said, has resolved symptoms on their own without intervention, but they may have multiple TIAs before, hopefully they don't ever have a stroke, but they may eventually have an ischemic stroke. So when they have that TIA, they need to see a neurologist, they need to be on medication, they need to do interventions to prevent an ischemic stroke.
So talk to us a little bit about what happens when a patient comes in and there's a language barrier.
Good question.
Good question. We have a lot of different resources here. We use something called CRCOM, which is a language interpreter phone. So essentially what it is, it's 2 headsets. And what we do is we call into a centralized location, so a third individual. In my instance, I would talk to the interpreter, and then the interpreter would then talk to the patient in their native tongue. So we use it a lot with Spanish, very effective. We also have the opportunity, we have a computer monitor that we can get a interpreter on that as well. Can be the same thing, it can be a live person for language interpretation, but we also use it for American Sign Language. Is done through
It's
that
almost like a
service.
video chat like this, so that they can talk to an actual person, which is pretty cool.
The majority of your cases that you see, do you think that they are, or would you say that they are related to drug overdoses and alcohol?
Good question. Hard to say the number of that, but I will say that in the ER, we see a lot of patients that have comorbidities. So what that means is that they have a variety of complaints that might be related to psychiatric, might be related to substance abuse, might be related to medical, and we have to see the whole picture and treat the whole patient for whatever's causing their complaint that's bringing them into the ER. We do see our fair share of substance use disorders, psychiatric complaints. That is a big part of it that we didn't really talk too much about during this presentation, but we are trained in helping those patients, getting them the psychiatric care they need. If that means rehab, withdrawal, symptomatic treatment, things like that. We are trained and capable. I wouldn't say that it's a majority, but people do experience, substance abuse disorders in conjunction with other disorders.
When is it, or how important is a patient's medication list to the emergency department?
I wouldn't say it's not important. We certainly review it. The big medications we worry about are cardiac medications. Blood thinners are another important hot touch for us. Most of a home medication list will not impact the drugs that we give in the emergency department. But say Coumadin, for instance, or warfarin, that's a medication that we like to know about, because we look at blood levels to make sure that they're not off the charts to where we would have to intervene for a patient that, say, has a GI bleed or something to that effect.
All right, so this talks a little bit about your work week. When working all week, do you have time to rest or not really?
You don't sleep, so.
So pros and cons, right? So Eric and I were both 3/12s a week as bedside nurses. Now we're 5 days a week, 8-hour days-ish. That's being generous. So we had more days off, but our days when we worked were longer. So when I would come off of 3 days of 12-hour shifts in a row, running my butt off in the ER, I would crash that 4th day, right? So I go home and I would just be a couch potato. So really my 4th day, that's my first day off, is not a very productive day, but I do rest. Now with the 5/8s, you're working more days a week, but it's not quite so labor intensive. But I would say that it was nice to be able to be flexible with the 3/12s. You can really spread out your schedule, and that's a perk that people love about being a nurse. You can flex your days. You work 3 in the beginning of the week, 3 at the end of the next week. Next thing you know, you got 10 days off in a row without using any vacation time. So you can really make your schedule what you need it to be. Works well for when people have kids and trying to figure out their schedule. So you rest when you can. Night shift. I did night shift for many years. Tough. You're working all night while everybody's sleeping, and you have to sleep during the day, so that takes some adjustment, but that's also something that has to be done, right? People need to work nights because people have emergencies in the nighttime. So yeah.
Can residents work 48+ hours?
Medical residents? I don't really know the logistics of medical residency. I don't know what the rules are regarding like hours working. I think that they do like on call, and like they're able to sleep while they're at work. So it's a little different than nurses. We don't have an area where we go take a nap during our shift. So we only do 12 hours and 36 hours in a normal period of time. Do you know if they're?
I'm not sure what the full extent is. I know, like Paige was saying, that there is a call room to where if they're on call, they can, get a nap in here or there, but I don't know what the limitation to that is.
Let's look. Okay, so talk to us a little bit about decisions on treatment and how they differ between pediatric and adult patients.
That's a really good question.
That's a really good question.
So I think the biggest decision factor for a pediatric patient is the level of emergency. So typically, if a pediatric patient comes in, there has to be a consenting adult with the individual or available by phone. So say a 10-year-old comes to the emergency department with their aunt, we would not accept that as a consent for treatment. We would call the guardian or the mother, father, whoever it may be, to verify that they're A, aware that their child is there, and B, are okay with us treating / releasing to whoever adult did bring in. Now there's some limitations to that as well. So theoretically, let's say 14-year-old female who presents to the emergency department but is pregnant, that would technically count as a consenting adult because she is with child. So there's some nuances to emergency medicine that we have to be aware of and take into account when a pediatric patient comes in. Now, there's also instances where, say, we get a trauma patient coming in, we can't get a hold of the mother because they were involved in the same accident and maybe got flown to a different hospital. Depending on severity, we can use their physician judgment, nursing judgment to step in and provide life-saving resources to that patient.
Like we said before, you can't not do it and then undo the not doing. So if a pediatric patient comes in and they're critically emergently needing assistance, then we do that. In terms of like the care overall between pediatrics and adults, it really just depends on the age of the person and the cognition of the person. So if we have a pediatric patient, of course, we have to treat them with kid gloves because they're kids. So we're not going to come at them the same way with an adult with our big old IV needle and tell them to hold still, you're getting poked. We try to treat them a little bit more gentler and with a little bit more care. But I will say too, when peds come in and they're really sick, we get a little bit more nervous. So to your first question with the sadness, I think that a lot of people are more affected when the peds come in and are really sick, and that kind of gets us into our adrenaline mode. We're ready, we're on top of it, we're hitting our marks, we're doing what we have to do because we know that we have to take care of this pediatric patient. So
totally agree. The unique thing is we have some specialized training in pediatrics that other nurses don't, and I think that's a take home for the audience is the education doesn't stop when you become a nurse. There is always constant learning here. And we always try to keep up with evidence-based practice because medicine's always changing. So what may work today might not be the same in 3 years from now. So there's that always growth curve there. And I think that's one of the unique aspects of this job is continuing to be able to grow in your profession, even though you've been doing it a really long time.
So are the instruments used in the emergency department different from in a typical outpatient office?
Yeah. I mean, some things are the same, right? So a blood pressure cuff is a blood pressure cuff. Thermometer is a thermometer. So things where we're checking vital signs, maybe getting your blood drawn in an outpatient lab, those things are the same. But then we have really specialized equipment that is specific to the ER. So things that ER nurses get to use that maybe other departments or other nurses don't get to use. So we have something called a rapid infuser. This is a really fancy machine that essentially pushes blood products into a patient that's bleeding out very, very quickly. So instead of just putting a normal IV in a normal bag and letting it drip in, this pressurizes that blood, shoves it into the patient in like 2 minutes, a whole 2 bags of blood. So that is really cool and really important because if a patient's bleeding out from a gunshot wound or a stab wound and we have to get that blood put back into them, now we have a device that we can do that. You won't find that in an outpatient office. That's an ER specialty equipment. So there is quite a few things that we get to do like that that are higher level, require higher training, and are specific to our department.
Yeah, we're very fortunate that we have a lot of state-of-the-art equipment in all of our ERs to
Yeah.
handle a lot of these cases.
Yeah.
From ultrasound machines to cameras, so you can see down and look at cords in the trachea for intubation. There's a lot of advanced things in the emergency department versus an outpatient office.
Yeah, and you're right. I did do a travel assignment in upstate New York that was a little bit less resources. So every emergency department is different. So they don't all have the same equipment. And that ER was a little smaller and it didn't have quite as much technological advanced equipment that we do have at Bay Health. So depending on where you're working, you may have to be creative with how you're doing a certain skill because you might not have the same equipment they have at the bigger facilities.
Mm-hmm.
Right, right. If a person suffers from a ruptured brain aneurysm, can the bleeding be stopped?
Good question. So there's no, similar to a cut on your arm, there's no way to go in and internally tamponade bleeding in the brain. Typically what happens is the bleeding will actually clot over top of that, which ultimately can be a positive, but also can be a negative. Depending on the amount of bleeding in the brain, it increases intracranial pressure, goes back along to the midline shift that Paige was talking about, and that's where you can suffer some pretty significant symptoms from intracranial hemorrhage. What they can do is go in and insert what's called a surgical clip, and they can utilize that clip in order to tamponade the bleeding, but unfortunately that also means making a hole of some fashion or form to do so. So it's certainly not a light procedure by any means, not something that would be done in the emergency department.
Yeah, and it really depends on the size of the bleed too. So we could have somebody that just fell from standing, hit their head, and they could have a small subarachnoid hemorrhage. Sometimes they are self-occluding, so they are not continually squirting out blood into the patient's brain. They kind of stop on their own, and then we would watch those. So we would medically manage, we would get repeat images to make sure it's not getting worse over days. So when the patient gets admitted to the floor, they'll get CAT scans every morning to see the size of the brain bleed and make sure it's not getting worse. If they do need interventions, they would go to an interventional neurologist to do some kind of intervention, again, not in the ER. The one thing that we do in the ER, though, as it pertains to brain bleeds, is if the patient is on blood thinners, which Erica talked about. So if they're taking something like Coumadin or warfarin, and they have a brain bleed, now our job is to reverse that blood thinner so that the blood is not bleeding as much, if that makes sense. So we want to fatten up the blood because it's too thin and it's bleeding too quick. So we'll give a reversal agent of their medication to help slow down that bleeding. Yeah.
Mm-hmm.
Yeah.
All righty. Do you have rights as a nurse to what procedures you might not want to participate in? Nothing like a good philosophical
Yeah,
question.
great question. So I'm really enjoying it. You know, you are your practice. You're taught how to do everything. If you are in a situation in which you are feeling really morally distressed, and you really cannot perform the function that's expected of you in your role, that would be a conversation with your immediate supervisor at that time, your charge nurse, your boss. Say, listen, this patient is having this done, and I personally cannot do it. And there should be a protection of you as an employee, right? We don't want anybody that is working in the emergency department to have these negative feelings, traumatic experiences, right? We have to protect the nurses. So Eric, as a manager, let's ask you, if one of your nurses came in and said, I really can't do this procedure, what would you say?
I would probably go do the procedure for them.
Or somebody else they're working with would tag in and swap patients, right? So there's always another nurse.
Generally, there's not a procedure that nurses don't want to be a part of. We all have our niche, if you will. Some people do not like sputum, so trachea suctioning would not be a favorite of one person, but someone else may be perfectly okay with it. So they may swap off tasks like that, and ER nurses get pretty creative in some regards.
Yeah.
All righty. There are two questions here that I think may be asked by the same person. Let me just ask the second one. If I had been good in science and biomed in high school, will I be a successful nurse and or athletic trainer? So apples and oranges there, but go with it. And also, can I put my mini-med certificates that I got here on my resume for high school? I'll answer the second part. Yes, you can. I don't know that these certificates are going to have any value for high school, but for application to undergraduate school, they would show an extended interest. Okay, so back to the question about if I've been good in science and biomed, am I well positioned to be a nurse or an athletic trainer? And go.
I don't know what an athletic trainer is. Like a personal trainer?
Yeah, I think they have like more sports.
Oh, like sports medicine
Sports,
kind of deal?
yeah, sports background. I think having a passion for a biomed slash anatomy slash any of the sciences probably would set you up well for being a good RN, right? There's a lot of science to the basis of what we do. I understand there was maybe a topic of conversation last week was about acid-base balances, and that there's a whole scientific piece to the human body, right? So carrying pH balances and all of that certainly ties in well to the nursing profession. It's always helpful from a pathophysiology standpoint to understand what your patients are experiencing. So to know why they're having those signs and symptoms, to know why maybe this person is reacting differently than the other person would, all of that's rooted in science. So I think that's certainly a solid structure.
Yeah.
As far as the athletic training piece, I'm not as familiar with that.
So we're both bachelor's and then master's prepared nurses. When you get your bachelor's, it's actually a Bachelor of Science. So it is a science degree rather than an art degree. So that does tell you that when you're going to be doing your studies in undergraduate, there will be a lot of science focused. But that's not to say that if science is not your strongest suit, that you cannot be successful as a nurse. There's plenty of people that have interest in history and English and other things that end up becoming a nurse. As long as you, get into the program and take it seriously and learn while you're there, then, you can be successful.
I think the bigger necessary factor would be liking people, right? Like that's what we do. Our jobs as nurses is interacting with people, and I think there's a fine art to that in a lot of instances, and I feel like that's probably one of the most rewarding aspects of the roles that we have. And I think that's why Paige and I like being at the bedside still, because we enjoy those interactions. So while we're in these leadership roles and we're genuinely interacting more with the staff that we work with, it's still nice to get out to the bedsides and hear people's stories and help make them feel better. That's why we got into this.
Gotcha. All right, this last one's a doozy. You have to break this down. How is a doctor of nursing different from an MD? So why don't you start with, what is a doctor of nursing?
That's perfect for you.
So there's a couple of different branches for nursing. So when you work your way up the nursing field, you can be a bachelor's prepared nurse, a master's prepared nurse, and then from a master's prepared nurse, you can be a nurse practitioner, and then you could be a doctorate nurse practitioner, or you can be more of a theoretical doctorate of nursing practice, which is more like research based. So there are different doctorate routes for nursing, whether you want to be patient care, which would be a nurse practitioner, or if you want to do more like research and theology. And then a MD or a DO, which is another branch of physician, those are typically more clinical based doctorates. So a doctorate in nurse practitioner is not equal to a medical physician. So we still have scope and standards of practice by the nursing board, and that allows us to do certain things. But the end all be all and the person with the highest level of education and the person that oversees the department is always going to be the physician. So here we have NPs and PAs, so nurse practitioners and physician assistants that work in the emergency department. They see patients independently. However, the MD or DO, the physician overseeing the department, is still responsible for all the patients that the PA and NP see. So regardless if you have a doctorate as a nurse or not, most of the time, at least here, you're going to have a physician that's going to be your resource as your higher level, right?
Yeah, I think from a degree standpoint, the biggest difference between an NP and MD would not be the education, but the actual clinical residency. So, anybody with a DO or an MD has gone through at least 4 years of residency in some fashion or form, training hands-on, one-on-one with a lot of these patients. So,
Alrighty, Eric, Paige, thank you so very much.
been our pleasure.
Next week, we're going to have Rebecca Robinson talking about radiology. See you all then. Good night.